using your laptop for audio and visual during the meeting, you can control the mute function on the Hangout. We kindly ask that those who are speaking to the group unmute their device. For the DURB board member, please reserve the question until the end of presentation or may ask in Google Hangout meeting chat. For public comment, if you would like to provide public comment, a conflict of interest form must be on file. Please send an email to medicaidpharmacy@utah.gov. Attendees that are not members of the DURB board, please enter your contact information in the Google Meet chat or email medicaidpharmacy@utah.gov. Please use the chat on the right if needed. Please provide normative feedback after the meeting to help us improve our process moving forward. Thank you. Dr. Catherine Smith, the chair, and Dr. Michelle Hoffman has informed us that they will be not available for the meeting today. So I will be follow the agenda today. Thank you. So the first order that we will have the housekeeping. And can I have, has anyone reviewed the minutes of the last meeting? And if I can have the motion on the minutes of the last meeting.
I noticed that the spelling of Descovy needs to be corrected in every occurrence.
Thank you, Dr. Turner. Anything else on the last minute? Can I have a motion to approve the meeting, the last?
Yeah, this is move to approve.
I'll second that.
And is that just to clarify, is that motion with the suggested amendments or edits?
Yes, with the correct spelling.
Thank you.
Thank you.
You can't come in here.
The next item is P&T committee update from Dr. Larson.
Yeah, the P&T committee did not meet in October, but we will be meeting next week to discuss immune globulins, and then we'll meet again in February to discuss continuous glucose monitoring.
Thank you for that. The next item will be Dr. Butterfield for, sorry, I think Jen, would you like to do a housekeeping for us?
Oh, certainly. Thank you. We had a discussion among our team about the start time for this meeting. And many months ago, we had changed the P&T meeting as a start time from 7:15 to 7 o'clock. And we were wondering, now that we're conducting remote meetings and we'll be doing so probably for quite some time, if a 7 o'clock start time would be amenable to the board. And if this is something that the board would like to do, I think it's not an official motion, but I think it is an item for discussion to see if starting at 7 would give us just a little bit more time to fully cover our agenda items and cover the materials that we bring to the board for review and discussion. And so I'd like to propose to the board that we begin our meeting at 7 a.m. and conduct it through 8:30. And in the event we finish early, then we can just move on to our other work for the day after that. So I'd just like to hear some feedback or thoughts on that.
I will say, as the mom of a toddler, that would be actually pretty challenging for me. It's often a struggle just to get here by 7:15 in terms of childcare and spousal meetings and work.
Okay. Thanks for that.
For me, either time works. I'm pretty flexible. Either one works for me.
I'm agreeable to either time.
Okay, thank you. And I'm so sorry, Kumar, I can't hear you. Dr. Britton, go ahead.
Oh, just either time as well. I know we originally changed it to 7:15 because of the challenges of childcare. So whatever works for the board.
Okay.
I'm fine with either as well.
Okay. Kumar, did you have a thought? Maybe you can type it into the chat if you're stuck on mute, or just go ahead. Down in the lower bar. Yes, you want to start at 7. Okay. I think I'm reading your sign language. 7 is correct. You would be good with 7? No, you like 7:15. Got it. Okay. Hi, Kyle.
I'm good with either time, Jan.
Okay. Okay.
This
So I'm
is,
here.
I mean, as a toddler myself, I kind of have a hard time getting up at 7, but I can make whatever you want work. That's
All
just
right. Well, I understand it. Since it's pretty open to the majority of the board, you're fine either start time. But there are a couple of you who prefer 7:15. We'll stick with 7:15 for now. My concern is that we have enough time to cover all the items in the agenda. So we'll revisit this if this becomes a challenge for us to get through the agenda. And of course, I want to make sure we have adequate time to discuss the items that are brought to the board. So for now, we'll stick with 7:15 and we'll revisit it later, early next year or later in the year if it is noticed that we need more time. So thanks for the opportunity to bring that to you and for sharing your thoughts.
Thank you, Jen. The next item on the agenda will be a comment from Dr. Butterfield for a spinal muscular atrophy. Dr. Butterfield, are you on?
Hello, this is Dr. Butterfield. Can you hear me?
Yes, we can hear you. Thanks.
Hey, good morning. I think the main goal is just to give a quick update on the therapies that are now approved for SMA, including one drug that is newly approved in August. The newer drug is called Risdiplam, or the branded name is Evrysdi, and it's an oral drug, which is its main novelty, but its function is in essence the same as nusinersen, which we've talked about before, which is an SMN2 splicing modulator. So if you remember, nusinersen works by, it's an antisense oligonucleotide therapy that covers up a splicing inhibitory site in the SMN2 gene and upregulates normal splicing of exon 7. So in essence, you make normal SMN product out of that gene, which is not functioning without the drug. Risdiplam does the same thing in essence, except it's an oral drug and has some other mechanism, but in essence upregulates SMN2 splicing to make normal SMN protein. And it's a drug we've been really excited about and appears to have really good efficacy, probably consistent with what we see in nusinersen. So it was approved by the FDA in August of 2020, so just a couple of months ago, for SMA patients over age 2 with any type of SMA and any age beyond age 2 months. So I think I said age 2 at first, but it's 2 months. The reason for not approving under 2 months was some sort of kinetics issue that required much higher dosing in younger babies. So far, the data are pretty new, so there's not published studies, but there's a number of studies that went into the FDA approval. They, in essence, mirrored the studies that were done for nusinersen. So there was a placebo-controlled randomized clinical trial of about 120 or 130 patients for type 1 SMA patients. And there was a similar placebo-controlled trial for older SMA patients. And the difference from that study from the study with nusinersen is that it included some older patients that weren't also seen in the nusinersen study. Basically, in every case, the drug showed significant efficacy on par with what was seen with side effects. There's some things about like nausea, vomiting, the kind of stuff you see on most every drug label, but nothing that was particularly concerning. We've been excited for this drug because of the possibility of treating kids with complex spine issues that are difficult to access by the intrathecal route. That's been a bit of a problem, particularly as kids get older with SMA, although we've managed to get our way through it. But also, we've felt like it's probably a good option for older patients who are probably not as severe as what we see in the younger, like type 1, type 2 patients, those young adult, adolescent patients with probably not quite as rapidly progressing SMA. In a sense, I'm still waiting for a couple of bits of data before I get fully on board with Ristaplam. They have ongoing study for pre-symptomatic patients, and this is where we've seen the biggest clinical benefit in SMA patients is in the pre-symptomatic kids. And for both Zolgensma, the gene transfer therapy, and nusinersen, we have kids with predicted type 1 SMA that are walking around and looking pretty normal, and we just haven't seen that yet with Ristaplam. Although I expect we'll see that at some point. I think its efficacy is on par with nusinersen, but I haven't seen that bit of data that would really convince me all the way. So the biggest issue that came up was not side effect, but a reproductive effect. And so this has really given us pause a little bit to just hopefully see some data mature. But there was some evidence in animal models for embryo fetal defects in progeny of female mice and rabbits that were treated with Ristaplam. And you guys who are pharmacists probably know these things better than me, but there's some numbers, which is the dose at which that effect goes away, and that was about double the expected human adult dose. So that was pretty concerning. And then in males, there's some infertility issues that they've seen. Again, all just in animal models, and the dose at which that goes away is about the same as the adult dose. And we have very limited data. I've asked the company a couple of times to get me some more discrete data about how often those things are happening, and a little more color around those data points. But there's just pretty much minimal data available at this point, limited to pretty much what's in the label. So that's the drug. We've been really interested in it. We have a number of people who are interested in taking it, and we've discussed some of these issues with them on the reproductive effects, and they want to proceed anyway. And we're really excited to have it as a tool in the toolbox. If it was the only drug we had, we'd all be throwing a big party right now. But with the nusinersen, I think a lot of patients are also wanting to just wait and see the data mature a little bit. That's mostly what I had to talk about, and maybe just there's a really rapidly emerging number of studies on nusinersen in older patients, which is one of the gaps in the studies before that show efficacy really across any age group or SMA type or condition with SMA. Even patients who are ventilated appear to be making significant functional gains on it. And we can go through that, or I can send some of those papers. I don't know that we have time to go through all that data in detail. And we've now had the gene therapy available for about a year. We've seen really amazing outcomes from that. And in our first two patients who were both predicted type 2 SMA and are now getting to about a year and a half old and looking essentially normal. So that's been really neat thing to see as time's gone forward. So I'm happy to answer questions. It's hard when I can't see people and be able to kind of see where we should head next. But if there's questions or anything, I'm happy to answer them.
Hi, Dr. Butterfield. Hey, it's Jen Strohecker, and I wanted to thank you for giving us some time this morning. I know you spoke specifically about Ristaplam, which is the topic of our DUR meeting today, but since you touched on Zolgensma, I think we're maybe curious to know too, as we look at all these therapies and their place of use, and understanding your excellent experience with them. Could you say, first of all, like the gene therapy Zolgensma, it's been out for about a year now. It sounded like you've had 2 patients that you've treated, maybe more with the clinical trials. But could you talk about outcomes? You said the 2 patients you treated were doing quite well and looked normal. But nationally, what are we seeing with Zolgensma at this point?
We're not seeing that come out as far as publications yet, but just by discussions with others, they're all having really positive responses to Zolgensma. And we've used it more than twice. The first 2 were both type 2 SMAs, so predicted that onset would be around 9 or 10 months, and the baby would fail to walk. And those were both last summer, so it took some time for us to kind of see that, kind of get through that age and see results. We just saw one of those kids a couple of weeks ago, and I can't distinguish him from normal, which is pretty remarkable. The other kid, I don't know if people saw this report on KSL TV about a month and a half ago, but they spotlighted him, and he's also looking basically normal. We've treated 2 type 1 kids with the gene therapy, one of whom is now 9 months old and looking essentially normal. What we've seen with our kids treated early, and this is true for nusinersen or Zolgensma, and sorry to use the brand name, but onasemnogena parvovirus XIOI, it's really long to say, but the Zolgensma kids are doing quite well. And what we've seen as we've monitored their motor progress with a couple of different tools is that they sort of trend in the normal range up until about the first year, and then they drift off to just under normal range, so that they're probably not distinguishable if you were looking at a kid like this from normal unless you knew what you were looking for, and they kind of just stay there at like sort of the 5th percentile of normal on a Bailey motor function scale. That would be for like a type 1 child. The type 2 kids really are just looking basically normal, and that's consistent with what we've heard from others. We have seen a number of adverse effects with the drug, and so that's always an issue, really limited mostly to liver inflammation that can be treated with oral corticosteroids in those cases. There's a couple of cases where patients needed to be hospitalized for more aggressive steroid therapy. And there's 2 episodes that I'm aware of where patients had like a microangiopathic HUS type of syndrome involving their kidneys. In both of those cases, I think there were some complicating factors, including intercurrent sickness illnesses in those kids that were a problem. So I think the overall safety has been good, and the overall efficacy has been really remarkable, particularly in those kids treated pre-symptomatically.
Great, thank you for that.
Okay.
Go ahead. Sorry, no, go ahead. I just wanted to thank you for answering my question. So go ahead.
Yeah. So the one issue we've run into with the newborns, and we've been newborn screening here since 2018, and probably had fewer cases than we expected. I think 8 so far, so in the almost 3 years. But the one thing we've seen that surprised us is how many patients have had positive antibody testing to the gene therapy. And this largely represents maternal antibody and puts us in a little bit of a pickle where we usually start nusinersen as a bridge to when those maternal antibodies wane and we can convert to the gene therapy. So that's a mechanism that we think is really important to have available to us. We had one case back in February where it was a discussion with the payer and delayed us about a week in treating the child, just because we were trying to work through that plan to start with, to plan, for an authorization to do nusinersen for a couple of months and then convert. We treated that patient at 20 days old with nusinersen, which was within our originally planned parameters for treating newborn babies. But in the time between 2 weeks of age and 3 weeks of age, that baby became profoundly symptomatic with SMA. He became really weak. My child actually aspirated after we dosed him with nusinersen and spent an extra week in ICU. So we're changing our goals a little bit with the timing for what we want to accomplish for dosing. And so that time pressure feels a lot more now than it did a year ago when we were kind of planning for treatment at 21 days. And having the ability to just work with payers to plan something like a start with nusinersen and conversion to Zolgensma, we feel like it's really important so we don't have to dance around it. I think in the future we won't hesitate though to just start nusinersen and have that conversation later if we need to.
Yeah, thank you for that. So there is and I'm sorry, I just have one more question, and then I'll give others an opportunity. But so Dr. Butterfield has been gracious to advise Medicaid pharmacy on its prior authorization criteria and help educate us as as this the treatments for this disease are rapidly evolving. And one of the things that you're mentioning is Spinraza prior to Zolgensma in the event that there's antibodies and you need to give them time to clear before you can treat the patient with gene therapy. But the other question that we had discussed last year, and I know you've looked at it on our criteria this year as well, but it's in a patient who has received Zolgensma or gene therapy, then follow-up treatment with a nusinersen or risdiplam at that point if there does seem to be sort of a progression of symptoms. And so I thought if we could just ask that, just because I know we're going to look at PA criteria here later. I don't know if you'll be on the call at that time because I know you need to go to a clinic, but the question for us just to understand place in therapy in a patient who's received gene therapy and then follow-up therapy with another agent if needed. What are your thoughts on that at this point?
My hope is that once we've given the gene therapy, we won't need anything else. I think the gene therapy is pretty definitive, although we're still pretty new at this, right? And so the first kids ever to get that therapy were treated in 2014, the ones on the clinical trial. And so we're really only 6 years into this. So there's a question of durability that we'll develop some understanding about over time. And certainly if we monitor these kids pretty closely as time goes on, if there was any question about some decline in function, I think adding nusinersen or risdiplam, we would probably push for that. But practically speaking, I don't know if we're going to see it. The gene therapy just seems to be that good. We are going to be a part of a study that we're just probably have started in the next year sometime with Biogen, who makes Spinraza to treat with Spinraza after gene therapy as under a clinical trial protocol. So we'll have some data to see if there's additional benefit. And particularly to these kids that I told you about, these type 2 kids, which were our first gene therapy patients that we saw since the commercial approval, they look normal. So I don't know what I would add to it, to be honest.
Yeah.
And so if we see declines, and as kids get a little older, we'll probably be doing motor function assessments about once a year to keep track of those things. But as long as we don't see that, I don't see that we would necessarily have a need to branch out. We're also going to have a few patients on nusinersen and risdiplam. That will be part of clinical trials, an existing clinical trial that is the long-term extension of the original nusinersen trials, and we got about 15 kids on that, still getting nusinersen through the trial. And Biogen has allowed those kids to go on commercial risdiplam, and we'll have probably 3 or 4 of those kids that are going to do that. So we'll have some data there too for combined therapy.
Great, thank you. And so, I mean, as we know, like you are a primary prescriber of this medicine, and we'll always work with you as a state entity to discuss patient care and considerations. But today in our PA criteria, again, because you may not be on the call when we get to it, there is this, if having received gene therapy, that Spinraza or Risdiplam would not be indicated at this time. So thank you for commenting on that.
Yeah. And conceivably, we would come up with a circumstance where we wanted to talk about it, as long as we had an option to maybe have a conversation if it came up. I don't think it will.
Yeah, thank you.
Our other big concern about authorization criteria is ventilated patients. And because that had initially been an endpoint of the clinical trial, so I think a lot of people had sort of not opted to treat ventilated patients. We had a couple of patients here who are full-time ventilated tracheostomy patients who had just not wanted to try the frequent spinal taps and all that because of the complexity of that in a ventilated patient, but are really excited to have Risdiplam as an option. There's data in ventilated patients and Risdiplam aren't all that well developed, but in nusinersen, there's really emerging a lot of data that shows benefit in those ventilated patients. And I think I sent some of those papers over, but I can resend if that's helpful.
Yeah, your comments on this are definitely well received, and that will be a topic for discussion for the PA criteria today as a recommendation. So. Sorry, and since I'm talking, are there other questions for Dr. Butterfield at this time? Okay. As always, Dr. Butterfield, we really appreciate your expertise and your willingness to share with us. So we appreciate the time you've given to Utah Medicaid today. Thank you so much.
Yeah, thank you. I'm glad to do it.
Thank you, Dr. Butterfield, and thank you, Dr. Strokecker. So the next item will be the review of Evrysdi and or generic of Risperidone from the University of Utah.
Okay, thank you. I'm going to go ahead and share my window with you. Dr. Butterfield addressed a lot of these points already. I do have some slides that I prepared with a little bit of background information, so I'll go over those again in case it might help seeing it visually. Are you able to see my slides there? Okay. So spinal muscular atrophy is a rare genetic disorder resulting from a deficiency of the survival motor neuron protein. I'll call this protein SMNP or SMN protein. A deficiency of this protein leads to loss of alpha motor neurons in the brainstem and spinal cord, progressive muscle atrophy, and severely compromised motor function. Most of the SMA population is on the more severe end of the disease spectrum with type 1 or 2 disease. Onset of neuromuscular deficits occur by 18 months of age in type 2 SMA and even sooner in the type 1 phenotype by 6 months of age. Patients with type 1 SMA usually need permanent ventilatory support or pass away by the age of 2 without SMA-specific treatments. The natural course of the type 1 phenotype entails that the child will not be able to sit unsupported, and with the type 2 phenotype, the child is unable to walk unassisted in the natural course of disease. Multi-system disturbances include feeding and swallowing difficulties, gastrointestinal dysfunction, cardiac remodeling, autonomic dysfunction, irregular bone remodeling, and immune dysfunction. Pain is a common complaint resulting from pressure sores, scoliosis, hip subluxation, fractures, and muscle cramping or spasms. So as you can imagine, nutritional management and respiratory support and orthopedic therapy and or surgery are commonly required, especially for infant and child onset SMA. Patient and caregiver quality of life are greatly affected as physical independence is lost with disease progression. In the fewer, less severe cases with onset later in life, such as type 3 SMA, Although key motor milestones such as walking are achievable, patients can gradually lose these abilities and ultimately lose ability to engage in school, physical activities, or employment, or lose independence in performing activities of daily living. The age of onset is a predictor of maximal motor milestones achievable or disease severity. Earlier onset is distinctive of a more severe disease. Disease severity is also related to the number of functional SMN2 copies a person has, since expression of this paralog gene yields some viable SMN protein. If a patient has more SMN2 copies, they generally produce more SMN protein compared to if they had less SMN2 copies. However, there is not tight correlation between the number of SMN2 copies and the phenotype, especially in the case of patients with 2 or 3 copies. This slide gives an idea of the distribution of patients per SMA type and the number of SMN2 copies most commonly found in each type. Patients with type 1 usually have 2 copies. Those with type 2 usually have 3 copies, and in type 3, 3 and 4 copies are most common. In type 4, these patients usually have 4 or more copies. So risdiplam is the third disease-modifying treatment to be approved for SMA and the second SMN2 splicing modifier, the first being nusinersen, the intrathecal injection. Risdiplam is the first oral dosage form approved for SMA. Both risdiplam and nusinersen are ongoing therapies, whereas the gene therapy onasemnogene is administered as a single lifetime dose. Both nusinersen and risdiplam are indicated broadly for the treatment of SMA. However, an age specification is provided in the indication for risdiplam, requiring patients to be 2 months or older. Onasemnogene is indicated for a more narrow age group for pediatric patients less than 2 years of age. The clinical development program for risdiplam assesses the safety and efficacy in symptomatic patients with type 1, 2, and 3 SMA, and that corresponds to the Firefish and Sunfish studies. And then there's a phase 2 active study in patients 6 months to 60 years of age, which is jewelfish, who have previously received treatment with other licensed or experimental drugs for SMA. There is also the recruiting rainbowfish study, which is for pre-symptomatic treatment in patients identified via newborn screening. Results from clinical studies in symptomatic patients have shown motor function improvements with risdiplam treatment in the type 1, 2, and 3 groups, and additionally improved survival without the need of permanent ventilation was demonstrated in type 1 SMA. So as Dr. Butterfield mentioned, in Utah, the newborn genetic panel includes screening for 5q SMA. So disease management planning can start promptly for positive cases. Based on the consensus statements from a panel of SMA experts, pre-symptomatic treatment is recommended for infants with genetically diagnosed SMA who have 2, 3, or 4 SMN2 copies. This updated recommendation, which included pre-symptomatic treatment for patients with 4 SMN2 copies, followed the market entry of onasemnogene. As for safety warnings, risdiplam labeling advises avoiding its use during hepatic impairment, but this warning could be modified since there is more data that will be coming out because it's been studied in a subpopulation with hepatic impairment. Based on animal data, use may impair male fertility or can cause fetal harm during pregnancy. And on page 22 and 21 and 22 of the report, you have considerations for the development of prior authorization criteria. I'll point out a few of these. You may require that prescribing may be limited to a healthcare provider experienced in the treatment of neurological disorders or in consultation with a pediatric neuromuscular specialist or neurologist specializing in SMA. Risdiplam was designed specifically for SMN1 related SMA, so you may require the provider's attestation or documentation of a genotype for genetic testing consistent with SMN1 related SMA. You may consider use to be within the approved weight-based dosing, and other considerations are regarding pre-symptomatic and symptomatic use. For example, you may wish to consider allowing treatment for all symptomatic patients, regardless of SMN2 copy number. And you may wish to restrict pre-symptomatic treatment to those with 1 through 4 SMN2 copies, keeping in mind that there is a recruiting risdiplam study in pre-symptomatic patients, and that's rainbow fish. So I'll go ahead and end with that.
Thank you, Valerie. Any questions from the board? All right. Thank you. So right now we're going to have the public comment from the Biogen US Medical regarding Spinraza or nusinersen from Dr. Rosalind Fint.
Good morning. Can you hear me?
Yes, thanks.
Hi. So yeah, this is Linda Finch. I'm a medical value liaison with Biogen, and I joined today to share some new data for Spinraza that I believe is relevant to your discussion today. So as you know, Spinraza was the first treatment approved for SMA in December 2016. We now have nearly 4 years on the market, and because of that, we've have broad exposure. Spinraza has been used to treat over 10,000 patients worldwide, with 3,000 of those in the US. And this includes babies as young as 3 days old and adults up to age 80. And more than 90% of patients who have started Spinraza remain on treatment. So Spinraza was approved after a robust multi-center sham-controlled clinical trial program, and it has a broad label, as mentioned, that supports use in children and adults of all ages with SMA. And as Dr. Butterfield referred to, several large, well-designed real-world studies have recently been published that support the safety and efficacy of Spinraza in adults. And in these studies, clinically meaningful improvements in motor function were seen in adults with type 3 SMA, and stabilization of function was seen in adults with type 2 SMA. And as also mentioned, Spinraza has a robust clinical trial program in pre-symptomatic babies with SMA. But there is a group of patients that have SMA who really haven't had as much opportunity to benefit from treatment. And these are the SMA patients that are ventilator dependent, as he mentioned. So patients that required permanent ventilation were excluded from our clinical trial program in our infantile onset study because our primary endpoint was time to death or permanent ventilation. And that was defined as tracheostomy or 16 or more hours of respiratory support for 21 or more days in the absence of an acute reversible event. So these patients weren't excluded because of a belief that they wouldn't benefit from Spinraza, but simply because they would have already met the primary endpoint. And during the trial, some patients did unfortunately become ventilator dependent, but they remained on treatment. So we now have clinical trial data, as Dr. Butterfield mentioned, showing that Spinraza treatment in these patients can be beneficial. So in the patients who required permanent ventilation, the Spinraza-treated patients achieved more motor milestones and exhibited higher motor function scores than those that were on sham treatment. None of the Spinraza-treated patients worsened on the Hammersmith Infant Neurological Exam, and 61% of them improved, actually, whereas with the sham-treated, 27% of those patients worsened. And then on the CHOP and 10 motor function, 78% of Spinraza-treated patients improved, whereas only 9% of the sham-treated patients improved and 82% of them worsened. The Spinraza-treated patients also required less time on ventilation and had a reduction in serious respiratory events during the study. And these results were achieved despite the fact that there were... Okay.
Thank you. Thank
All
you.
right, thank you.
Thank you for your comment. The next item will be another public comment from the Genotac regarding the risperidone from Dr. Michelle Puyer.
Hi, good morning. My name is Michelle Puyer. I'm with Medical Affairs at Genentech. And I'm only going to make a couple comments because the Unity and Dr. did a great job of already going over the key highlights of the process. But just to remind you, this is the only
Dr. Puyer, I apologize, it could be from me, but that's really hard to, the echoing is kind of bad.
Oh, is this better?
A little,
Much
yes.
better.
I see. Okay.
Oh, there goes Jim.
Oh my goodness.
You may want to call in via the audio option at the bottom of the Google Meets window. We can give you a few minutes to do that.
Okay, is this better at all?
This is better.
Okay. Usually it's the opposite. I apologize. Yeah, just a couple comments since Dr. Butterfield and obviously the university did a great job of overviewing the product. Risdiplam, just wanted to point out that it is an oral product, so patients can take this at home. And some of the patients who may not be able to take an initial injection or just prefer an oral product. This is something, particularly in the age we are in now, where a lot of patients don't want to go into a medical facility, is really important to consider. And not only that, but our clinical studies did provide an overview of patients, or did include patients who typically wouldn't have been just as product for the committee. We really appreciate it. Thank you.
Thank you for your comment. I think the last part was quiet echo. The board have any question?
I've got a question about risdiplam in young infants. Sometimes those children are not getting everything that's put into their mouth or spitting it up, and I wondered if that was addressed in the studies. How is that handled to make sure that the child is getting all of the dose that they need and not losing I guess a pretty important, expensive medicine.
Brian, can you hear me?
Yes.
Okay. I'm not really sure what's going on with the connection, but yes, you're absolutely right. This is an oral product, and the recommendation for for patients, obviously, if babies are spitting up, is not to redose, number one. So obviously, if you forget the dose, you take it in 6 hours or else wait till the next day. But if the baby is spitting, you would not redose with the product.
Okay. And is the efficacy still there in those newborns that, again, sometimes not everything that goes into the mouth stays in the mouth? Kind of slobbery.
And sometimes things that shouldn't go in the mouth, right?
Right.
Yeah, no, we have not seen, from the results of the studies, we haven't seen any issues with that. So although we haven't studied exactly like how much, potentially would have been spit up, it's really hard to detect, but we have not seen it impact the clinical trial results.
All right, thank you.
Mm-hmm.
Any other question for Dr. Puyer? Thank you, Dr. Puyer, for providing the comment. The next item will be the Utah Medicaid pharmacy team going to present the prior authorization for Ristalam and nusinersen.
And I don't have that up. I am unable to pull that up right now. Brian, can you?
Let me check just a second.
Let me try to present. You able to see the criteria?
Yes, thank you.
There we go.
Thanks. So this is the criteria from Utah Medicaid. Criteria for approval. The patient has to meet all of these criteria, 5 first criteria. This medication is prescribed by or in consultation with a physician who specializes in spinal muscular atrophy treatment. Patient has documented diagnosis of SMN1 mutation consistent with SMA, or documented pre-symptomatic SMA treatment with homozygous gene deletions of SMN1 and less than or equal 4 copy of SMN2. Assessment of motor function development milestone using age-appropriate screening tool. Trial and failure of referred treatment per Utah Medicaid PDL or prescriber must demonstrate medical necessity for non-preferred product. Currently, right now, the nusinersen and Zolgensma are both referred. We haven't placed the Risperdal on the PDL yet. Patient has not previously received Zolgensma. Additional criteria for Spinraza is applicable. Please provide the date of the last Spinraza treatment. The reauthorization criteria is updated letter of medical necessity or updated chart note demonstrating response indicated. Evrysdi or Risperdal authorization is 1 year. Spinraza authorization is 4 doses over 58 days, then 1 dose every 4 months, up to 1 year. Reauth for both is 1 year. We have a note that initiates Spinraza treatment with 4 loading doses. The first 3 loading doses should be administered at the 14-day intervals. The 4 loading dose should be administered 30 days after the 3rd dose. A maintenance dose should be administered every 4 months thereafter. Per Dr. Butterfield comment about ventilator, we have removed that criteria.
Comments from the board? We may have lost Noon.
Any comment from the board?
There we go.
Okay, if there's no discussion on the PA criteria as presented, we'd like to ask for a motion to approve the prior authorization criteria as presented.
Move to approve prior authorization criteria.
Thank
I'll
you,
second that.
Rosa.
Okay.
Thank you, Kumar. Any objection? Okay, we can move to the next item.
I think we need a vote.
Voting.
Yeah.
All in favor?
All in favor?
Aye.
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 Thank you. The next item will be the HER2 positive target therapy prior authorization form. We have a public comment from Seagen Incorporate regarding application from Dr. Michael Hazirato. I'm sorry if I'm pronouncing your last name wrong.
Close enough. Oh, do you want me to go right now?
Yes, please. Thank you.
Yeah, actually, I looked at the agenda. I didn't realize that Takaiza would not be reviewed today. If Takaiza will be reviewed in the future, I will gladly yield my time to the committee. But if you feel like you'll benefit from an update, I can give you a 2-minute and 30-second overview. I'll defer to you guys. What do you think?
I think, yeah, if you have been prepared to come to our meeting, we would like to hear
Awesome.
the update.
All right.
Thank you.
Sounds great. Hi, everyone. My name is Michael Pazarande. On behalf of Seagen, we respectfully request the Utah DUR board to consider the inclusion of tucatinib in combination with trastuzumab and capecitabine as a Utah PDL option. Now, Takaiza, generic name tucatinib, is an oral highly selective inhibitor of the HER2 tyrosine kinase. It is indicated for the treatment of adult patients with advanced unresectable or metastatic HER2-positive breast cancer, including patients with brain metastases who have received one or more prior anti-HER2-based regimens in the metastatic setting. This request is supported by the overall survival OS benefit data observed in our pivotal phase 3 HER2 CLIMB trial. Now, despite recent treatment advances in HER2-positive breast cancer, there are very few pivotal trials that have demonstrated an OS advantage in the metastatic setting. In addition, up to 50% of patients with HER2-positive breast cancer develop brain mets during the course of the disease. Now, patients who have brain mets have historically been excluded from clinical trials due to poor prognosis. This was the exception in our HER2 CLIMB trial, where almost half the patients actually had brain mets. And this is really important as higher healthcare resource utilization and costs are associated with breast cancer patients who have brain mets. HER2 CLIMB not only included patients with stable brain mets, but even include patients with active brain mets. The tucatinib combination showed a statistically significant and clinically meaningful reduction in PFS as well as OS, not only in the intent to treat population, but also in the brain mets population. Adverse events in the combination of tucatinib, trastuzumab, and capecitabine occurred at rates similar to those observed with just traz and cape alone. The labeling for Takaiza contains warnings and precautions for diarrhea, hepatotoxicity, as well as embryo-fetal toxicity. Lastly, the NCCN guidelines added tucatinib plus traz and cape as a category 1 level of evidence for systemic metastatic disease in the breast cancer guidelines, and has also added the combination to the CNS central nervous system guidelines. Thank you for allowing me to provide a very high-level overview of the data supporting tucatinib as a Utah PDL option. Thank you very much.
Thank you. I'm going to present our criteria for the HER2 positive therapy. Sorry, I'm having a little technical problem.
I can present it now.
Yes, would you, Joe?
Tell me when you guys can see it.
Yes, we can. Thank you.
Thank you. If you're able to make
You
it a
wanna
little
dis-
bigger, that might be nice.
Okay. And Noon, do you want to discuss?
I can go through the criteria. In the table will be all of the indication FDA approved for the Herceptin and its biosimilar and HER2, Casila, Northland, Acheta, Tukisha, and Tykerb. They all having different indication regarding unresectable breast cancer, adjuvant early breast cancer, adjuvant breast cancer, metastatic breast cancer, and metastatic gastric cancer. Criteria for approval, all of these criteria have to be met for any of these products. Documented diagnosis of requested indication, labs and tests confirming tumors are the HER2 positive. Patient not receiving in combination with anthraxolin due to significant cardiac toxicity. Plan to monitor cardiac side effect by measuring left ventricular ejection rejection at baseline and subsequently schedule appointment. Describe patient is not pregnant. The plan to monitor cardiac is the exception to Tukisha. There's additional product specific criteria for Enhertu is receiving 2 or more prior anti-HER2 based regimen and plan to monitor for sign and symptom of interstitial lung disease. For Casila, additional criteria is receive trastuzumab and or with taxane treatment previously. Confirm no active liver disease like hepatitis B or hepatitis C. Has a plan in place to monitoring serum transaminase and bilirubin prior to the dosings. For nerdlings, to be approved for metastatic breast cancer with nerdlings, the provider needs to figure out the criteria that the patient have received 2 or more prior anti-HER2 based regimen. For Pacerta, plan to evaluate cardiac function prior to and during treatment and used in combination with trastuzumab. For Tukisha, receive 1 or more prior anti-HER2 based regimen previously, used in combination with trastuzumab and capecitabine. For Tykerb, receive prior therapy with anthraxolene, taxanes, or trastuzumab, and plan in combination with capecitabine. Plan to do liver function tests before initiation of treatment, during treatment, and as clinically indicated. Any comments and feedback from the board?
Yeah, hey, this is Kyle. I had a question about those requirements for combination therapy with the 3 TKIs that were discussed. Oftentimes there are toxicities with the combinations, and so sometimes the capecitabine will be dropped, just a lot of times for diarrhea. And so would that then prevent the prior authorization from being approved if they were to drop, one of the 2 other medications?
That is a really good comment. This is a criteria that we developed from the FDA approved indications for this product. But if there is a clinical appropriateness, if the patient is experiencing side effect from one of the 2 agents, we would refer the provider, provide like a really detailed and rationale. We can always discuss that criteria.
Yeah, I just think there needs to be an avenue for dose reductions or dropping one of the 3 medications due to toxicities, because these HER2 active medications would still be important in those situations, but you may not be able the patient may not be able to tolerate all 3 medications at one time, or or both, depending on which regimen they're on.
Would it be beneficial if the language will be used in combination with certain product if appropriate and or tolerate?
Yeah, I think so. as long as there's, I know that's the indication, and that's of course what we're trying to pursue, because that's where the data is. But sometimes it's not reasonable to continue therapy with all three products.
Makes sense. We can add the language on that. Thank you.
Yeah. Thanks, Tom.
I'm not sure where the language should go for that, but I think in clinical practice, most experienced oncologists will be adjusting regimens, and I think this is a very difficult document. I commend you for getting it all straightened out. And I'm not sure how you're going to keep it up to date as the trials come in, because they do so frequently. But I think finding a place for that language so that, as has just been said, we don't limit the treatment, because I think, patients' responses are quite variable, and in clinical practice, those regimens are often adjusted according to tolerability, and there are standardized toxicity ratings that are used. So wherever you can, I'm not sure if you want to put it up above so it doesn't have to go in on every line. I'm sure you can figure that out, but I agree, something to indicate that won't preclude therapy altogether.
Or would the board refer to have that combination criteria to be removed?
No, I think it's a language that would say it's treatment according to tolerability somewhere. It's a little hard without seeing the whole document, kind of where you would put that, maybe up above.
Yeah, I agree. I don't know that it needs to be removed, because that's your starting point, because that's the indication. But just the ability to back down from that is all I'm really saying. And maybe that's built into the process anyway, and it goes without saying on the PA form, but I don't know. I don't know that policy.
I wonder if, because under all the ones that have used in combination with, if you added used in combination with or documentation of, something with, that, or with documentation of clinical I'm having trouble coming up with the language, but of a clinical reason for not doing that, basically.
Yeah, I'm trying to see where it could be one line up top so that we don't have to repeat the comment on each agent there, just to say criteria for approval, all requests where all criteria must be met. Something to the extent patients are being treated according to tolerability. And I do think, to Kyle's point, I do think that it may be built into the process. So I'm not sure what we're trying to say there. Or you're concerned that we would not meet the criteria for the PA if something had to be dropped, if dosing had to be dropped down or out. Is that the concern?
Yeah, and it's happened with other payers where you can't get the product approved, even though there's perceived benefit to be gained from Tukysa, for example. But you can't get it approved because the patient is not in a position to tolerate capecitabine and Tukysa and the associated diarrhea,
And we can add those edits. We were IMing. I'm just uneasy about trying to edit it live. We're having audiovisual problems today. So thank you for those comments. We'll put some language in at a later time. we appreciate those thoughts. So
Yeah, so it could just go up, probably just go up to the top as a one-liner that that goes ahead of all the agents. Then you don't have to put it in on each one. Yeah, thank you.
I like that.
Yeah.
I like that. Thank you.
Thank you for.
We'll need to.
Any other comment and feedback regarding any other criteria? If not, can we have a motion to approve?
So moved with the edit as has been discussed.
A second.
Thank you. Any opposed? Can we have a voting on this motion?
Aye.
Thank you.
Aye.
Aye.
I apologize. Can we also do circling back to the minutes? I believe that we have a motion. Can we have a second on the last meeting minutes? A motion to approve the last meeting minutes?
Motion to approve.
Thank you, Kuma. Thank you, Dr. Wanston. A second?
I'll second.
Motion to, sorry, a voting?
Aye.
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 Any objection? I believe that should be all unless I'm missing anything, Jen. Okay. Any abstain? Okay. So we will have the next meeting on Thursday, December 10, and we will be discussing a newer antipsychotic agent. Can I have a motion to adjourn? Thank you.
I'll second it.
Thank you, Dr. Khan. Abstain and approve. Okay. All right. The meeting is now adjourned.
Have a great week, everybody. Have a great weekend coming up.
Thank you.
Thank
Thank you.
you.
Thank you.
Thanks, everyone.